Well, good morning, everybody. I'm Christian Soura, and I'm here to talk about telehealth policy at the federal and state level, which is a pretty broad topic, but we'll see where we land from here. So I'm the vice president for policy and finance at the South Carolina Hospital Association. I've been here for about 3 years. Prior to that, I led the state's Department of Health and Human Services and was the president for the National Association of Medicaid Directors. And between Pennsylvania and South Carolina state government, had a number of positions with responsibility for budget and policy and other duties as assigned, as they tend to put at the end of all of our position description. So, that's the topic I was assigned, and when you get something that broad, you try to figure out what are the different elements of this that are sort of worth focusing on. So I thought, it makes sense to spend a few minutes talking about what federal telehealth policy looked like before COVID, what has changed during the course of the past several months, how have they changed those policies, from a mechanism standpoint, what's the process they've gone through to change those policies, and why exactly does that matter? What has the state done? What has the state done as part of their response? And then, where do we go from here? What's the next thing to come? And, one of the first questions, I guess, when you look at that bullet point list is, who makes the decisions about what telehealth policy exactly looks like? And of course, it changes quite a bit from, sort of insurance type to insurance type is at least one way of thinking about it. So when it comes to Medicare, Congress and then the Centers for Medicare and Medicaid Services make a number of the critical decisions. You think about Medicare Advantage, and at that point you start to add the MA plans, the insurance companies themselves that are responsible for the administration of that program in some way. When you get to Medicaid, and now you have the state and federal partnership, and so you have all the folks who are involved in making policy at the federal level, and then you add in state Medicaid agencies, you add the state legislature, which involves itself sometimes through permanent law, sometimes through the budget or through the language that accommodates the budget each year. And then depending on what kind of a Medicaid beneficiary you're talking about, you're also potentially looking at the managed care plans. Right now in South Carolina, about 3/4 of our Medicaid population is in managed care, but there are still a number of groups that are outside of it and still on a fee-for-service basis. And then you get outside of those public insurance options and you get to the self-insured plans. Congress and then several different federal agencies have roles in setting policies, specifically telehealth policies as well. And then for the fully insured plans, you have roles for state level actors at the same time. So, already you can sort of look at this and think, when this is already getting messy, right? You already have a range of executive and legislative authorities, sometimes at a couple different levels of government. And they make policy in different ways, whether it's through statute or through regulation, through administrative decisions. There's any number of these things that you have to look at on top of each other, and occasionally you even have court decisions to think about. So what did federal telehealth policy look like once upon a time in the pre-COVID era? A lot of it is focused on Medicare coverage. To some degree, the feds are also involved in deciding what Medicaid coverage looks like for telehealth. But in many respects, the feds have deferred to states to make decisions about what their state plans should look like or what their waivers might look like for certain Medicaid populations. The feds do have, an important role in enforcing HIPAA. And so that kind of comes up when you think about what platforms are or are not going to be permissible for the delivery of telehealth services. And then there's sort of just, non kind of coverage related telehealth policy. So, here are a couple examples, and we'll get a little bit more into the Lifeline program in a few minutes. But, these are examples of other policy decisions that federal actors make that affect our ability to have access to telehealth services. And specifically what we're talking about here is the kind of connectivity. If you don't have access to sufficient, broadband or, then you're not going to have meaningful access to telehealth either. So on the Medicare side, is a general rule, and there's a handful of these kind of general rule kinds of things that we probably have to think about in the next few minutes. But, big picture, Medicare coverage was focused on designated rural areas, and it was focused on patients who left their home and went to a certain kind of medical facility in order to receive service. So there were a number of rules and restrictions that really walled off a lot of the possibilities for telehealth for Medicare beneficiaries. But they've done quite a bit to work on sort of tearing down those walls over the course of the past few years. I mean, I think right now there's a tendency among folks to look at sort of the COVID era and then the period before it without seeing any kind of transitional time or any kind of gray in between. But what I'll show you in the next minute or two is that I think there's actually a pretty compelling argument that we've actually been making meaningful transitions for the past couple of years towards a more permissive federal policy on the telehealth front, even prior to COVID. So one place where you see that is in the 2019 physician fee schedule. All the drafting and releasing and commenting of that stuff actually happened in 2018, which is why there's a bit of a discrepancy here with the years on the slide, but you get the idea. So, one of the things that came out of that was Medicare coverage for store and forward. And so, store and forward is, to use maybe the governor's, favorite example of it. He likes to tell a story of a time when he was sitting in the back of his car and was, headed off to some location, and he had something kind of, bothering his his eye. And so he decided to take a picture of it and then send it off to his MD. And then his MD got back to him later and said, you don't need to worry about it. This is what that probably is, and here's what you do about it. So, without knowing it, the governor became sort of a poster child for store and forward because he got a remote evaluation of his eye. He got it within 24 hours, and that's basically what that service is all about. Virtual check-in. In this case, it's a very brief, medical discussion. These tend to be just a few minutes. One of the things that I think people have tended to think about with virtual check-in services is that, this is a service that potentially displaces what would have otherwise been a face-to-face encounter. And in a little bit, we'll come back to, why that might or might not be relevant. In general, these changes that were made in the 2019 schedule were for established patients. So you had to have a relationship between the provider and the patient. And there were rules written into the final version of this rule where, CMS wanted to make sure that nobody was double dipping, right? That, you weren't, as a provider, being paid for face-to-face encounters and then also trying to get paid extra sort of above and beyond that for these kinds of, follow-ups or other check-ins. And, I guess I can say this myself as a former, sort of insurance side person. You tend to think of the most paranoid examples, and you tend to think of different things people are going to do to try to rip you off or defraud you. And so you write policies with a fair amount of paranoia in mind, and I think CMS engaged in a little bit of that kind of behavior when they created these codes. Patient financial responsibility is worth mentioning. So, one of the, sort of meaningful distinctions, and again, this is kind of a general rule, but between Medicaid and Medicare is that, for Medicare, patients often have to reach into their pocket, at least to some degree, depending on what kinds of services they're receiving. And so there's a little bit of a financial incentive, and you have a bit of that kind of financial lever as a policymaker when you're trying to change the behavior of beneficiaries. While on the other hand, for Medicaid, everything's basically free to the Medicaid beneficiary. And so you don't really have that ability to try to get them to think differently based on that. So, patient financial responsibility matters, not just because patients who receive these services might have to pay a little bit, but also because of the fact that they have to pay a little bit, that tends to bring, sort of questions of consent into the process as well. So, how do you make sure that people who use these services understand that it's not necessarily free? They may have to pony up a little bit. So that's 2019 fee schedule. In 2020, we saw new codes established for e-visits, and in that case, these are patient-initiated, requiring some kind of clinical decision. And here, I think it pretty consciously and explicitly, even in the definition, talks about the idea that some of these codes are being established so that they can replace some face-to-face encounters. Again, from a policymaking standpoint, when you're making decisions about creating new codes, you're trying to figure out, how am I changing the incentive structure for patients, and how am I changing the incentive structure for providers and for other insurers who may be part of the mix? Especially in some of these cases, if you can create a new telehealth code that is relatively inexpensive and have that code replace a potentially more expensive face-to-face visit, then it does change the math and change the dynamics a little bit when you think about how to sort of build your broader coverage platform. And then there's the Support Act. So the Support Act is 650 some pages of language that was meant to fairly comprehensively get at different elements of the opioid crisis a couple years ago. And one of the things in the Support Act is language that basically says Medicare patients who have a substance use disorder diagnosis can receive telehealth care for that condition. And this explicitly set aside, and this is Congress now at this point, setting aside some of those historical geographic limitations, allowing the home to be the originating site, and being explicit that they expect practitioners to be paid as if the care had been rendered in person. So, the last slide talked about a couple of rules, proposed and then final rules that were submitted by CMS and the executive branch. Here we have Congress acting affirmatively to try to knock down some barriers to telehealth policy. So, you have this couple-year period where there's, meaningful democratization of telehealth services, from the federal policymaking perspective. Telehealth is made available to more people. It is made available in more settings. It is explicitly chosen by Congress and by CMS as the preferred mechanism for addressing social problems and healthcare problems that they have not been able to fix otherwise. And it's also one of the few places where anybody in America, an American health policy, can agree on anything anymore. So folks, Democratic and Republican voted for this stuff, and the executive and legislative branches, which didn't necessarily agree on much else, did agree that these were important changes to make. So, meaningful movement on the telehealth front, even pre-COVID. And then, of course, once you get into COVID, everything really accelerates. I should probably note at this point that this portion of the presentation is being pre-recorded. So if I use the future tense now to explain something that may happen and you're thinking, what are you talking about? That happened a week ago. That is the reason for it. But as of right now, there have been 4 meaningful packages that Congress has passed so far that relate to COVID. CMS is engaged in a number of regulatory actions. We'll get into a little more detail on that in a minute. CMS has also put out more press releases and fact sheets than anybody would be able to count, and so-called sub-reg guidance. So sub-reg guidance is sort of sub-regulatory, just sort of letters and memos and other things they publish on their website. And then Section 1135 waivers, which are going to get a little bit more attention here because they are really key to the federal telehealth sort of loosening that we've seen in the past few months. I don't think we need to go exhaustively through the 80 gazillion pages of federal healthcare policy that have come out recently. But I think suffice it to say that the overall direction of federal policymaking during the COVID era has been to eliminate barriers. Although in general, they are eliminating these barriers in a very time-specific and limited kind of way. So getting rid of some of the rules that have historically, blocked access to the telehealth services for certain beneficiaries, allowing more forms of telecom technology to be used, in some cases, just even the telephone, setting aside some of the pre-existing relationship rules, letting different clinics serve as, as sites for these visits, and allowing patient cost sharing to be set aside or reduced, at least in some ways, for Medicare beneficiaries, whether they're fee-for-service or in Medicare Advantage. 1135 waivers. So maybe a quick backgrounder on what the story is of these things. So the concept behind these waivers is that is the belief that during an emergency, the HHS secretary should have the ability, and this is the federal HHS secretary, should have the ability to make decisions that ensure that people who are beneficiaries of public insurance programs, Medicare, Medicaid, and CHIP, that they can continue to have access to the healthcare items and services they need, and that the providers who are offering these services can have confidence that they're going to get paid for this work, even if the secretary has to set aside a few rules. But there's always some kind of catch-all provision at the bottom that says none of this latitude applies if you engage in fraud or abuse and so forth. So, the punchline is that these waivers are about ensuring that access to and reimbursement for healthcare services continues, but for people who are already enrolled in these programs. So, one thing people tend to ask is these 1135 waivers, can I get more people covered? Can I give, services to other people? And the answer is really no. I mean, you can't add new people to these programs through these waivers. You can just sort of knock some of the rules out of the way that you need to suspend, during times of some form of crisis. And there's a few preconditions to getting these waivers accomplished. And, first you need the president to do one or both of these things, to declare an emergency or a disaster according to one of a couple of different federal laws. You need the Secretary of Health and Human Service to determine that a public health emergency exists. And then the secretary has to fill out a little bit of paperwork and send it off to Congress. That one's a little bit less exciting. And the thing to remember here basically is that both the president and the secretary need to turn their keys in order for an 1135 waiver to exist. And both of them need to, under those laws referenced on this slide, they both need to every once in a while revisit their decision and confirm that they want that declaration or determination to continue to apply. So it's not a set it and forget it kind of thing. You need to come back and revisit these decisions after you've made them. So who cares, right? Why are we spending so much time thinking about 1135 waivers? Well, the answer is that almost all of the telehealth flexibility we've seen in the COVID era has been issued by CMS administratively under the authority of an 1135 waiver granted by Secretary Azar. Which means that these waivers need both the president and the secretary to continue to believe that the emergency is present and that the public health emergency is ongoing. If either of them decide that it's time to unwind that, then this flexibility will be lost immediately. So there's nothing in the statute that creates these waivers that puts together any kind of transition period or anything like that. So if the next renewal comes up and at the last day they decide, never mind, there's no public health emergency anymore, all of this flexibility we've seen in the past few months will be gone overnight. So, what is the future of this then, given that kind of level of risk that's out there? Well, one is we've seen a number of members of Congress introduce legislation that would make some or all of this flexibility permanent. None of those bills have gotten to the finish line yet. And given where we are now in the election cycle, there are relatively few session days left this year for Congress to act. And people just aren't really in the cooperative mood typically when they're racing off to the ballot box. The next decision on the public health emergency is due, I think it's around October 23rd, which is immediately prior to Election Day. I mean, so there's going to be a lot of context for the next decision that Secretary Azar needs to make. Even the regulations that have been put out on telehealth flexibility are generally tied to the period of the current public health emergency. So if the public health emergency, if that finding is withdrawn, then those rules won't be operative anymore. And there's only a couple little segments of the flexibility that we've seen in the past few months that might survive if the declaration were to end abruptly. And that relates pretty specifically to FQHCs, rural health clinics, just because of the way Congress worded one of their bills. So, things to think about in the post-COVID era. When is the administration going to pull the plug? When will they decide that, when will the president change his mind about the national declaration? When will Secretary Azar decide it's time to end the public health emergency? We don't know. When, if ever, will Congress act? Some of these restrictions that apply to Medicare are statutory. And so if they are hard-coded in law and Congress put those restrictions there, then only Congress can unwind those restrictions. CMS can't set aside restrictions that Congress put there in the first place. They can just sort of create flexibility when Congress has given them the ability to create that flexibility. And then what's CMS going to do next? So, one thing that we've seen that is actually in the comment period right now anyway is the 2021 physician fee schedule. So you remember a few slides ago that it was through the 2019 and the 2020 rule that CMS, created some movement on the telehealth front, and they proposed to do that in a somewhat different way in 2021. This slide, which you may or may not be able to read, gives a bit of a summary of what that 2021 rule looks like. I put it up there, not expecting anyone's really going to be able to, comprehensively scan this in the few seconds we're going to be here on this slide. But to point out that, one, if you want to go and take a look at that 2021 rule, there are important tables in there that get all the way down to sort of specific billing codes and talk about what CMS is proposing to do. So, short version is that CMS has created lots of flexibility in the past few months on the telehealth front, and they have decided that they have created more flexibility than was necessary or appropriate. And so what they want to do in sort of group one across the top of this table is take some of the codes that they've allowed to be billed via telehealth in the past few months and allow those things to continue to be billed via telehealth for the foreseeable future, just sort of indefinitely. So that's what kind of the top box gets at. The sort of shortest box in the middle at group two, what they're focused on there is in future public health emergencies, what are the kinds of things that should be billable through telehealth when the next event like this occurs. And the largest block there at the bottom, those are codes that they're saying, well, we decided that these probably don't need to be available through telehealth anymore, but we're open to your comments. And so comment letters are due October 5th through the normal, sort of regulatory commenting process. And they've openly said, we are open to comments on these things, but we do want you, as you submit comments, to give us very specific evidence and rationales as to why you think, any of these codes should still be available through telehealth. I mean, they basically said the burden of proof is on you, I guess is a way of thinking about this. So, closing out the federal stuff, progress on telehealth at the federal level requires a mixture of congressional and executive action, depending on which rules you're trying to get rid of, which barriers you're trying to overcome. They have different places they exist. Some are in regulations, some are in statute, and that affects how you try to get rid of those things. The fact that there is a patient financial responsibility component in Medicare does add a little bit of additional headache, when it comes to thinking about how to unwind or live with some of the restrictions that are out there today. Even when federal programs are out there, they do still have to live with state licensure rules. So there have been a number of things that the feds have done to try to allow providers to work across state lines during the course of the past few months. But the feds can't suspend state licensure rules. So, I mean, they can create the ability, I guess, to have flexibility in some ways, but they only have so much control over that from the center in Washington. And then, COVID. I mean, COVID certainly accelerated telehealth adoption, but again, that momentum had already been building for a couple of years prior to COVID. This just really kind of sped things up. And then, of course, you got this big X factor, the election. What does that mean? What does it mean for control of Congress? What does it mean for control of the White House? Telehealth is not, mercifully, telehealth is not one of those areas where there's a clear red state position and a clear blue state position. I mean, going back to the Support Act again from a few minutes ago, we saw good bipartisan interest and support in moving those things forward. So state telehealth policy, a lot lives here, right? I mean, insurance is generally regulated at the state level. Providers are largely regulated at the state level. Medicaid program, is meaningfully driven from the state level, although you need lots of different federal approvals to get things done. If that's the case, then why do we do the feds first? Well, because the state doesn't really do a whole lot when it comes to Medicare. States can't do much to touch self-insured plans under federal law. And especially when I think, about the flexibility that we've seen created in the past few months, in many ways, the states are looking at what the feds are doing and are just kind of following along, a few steps behind. So it made sense to talk about the feds first. When you're looking at states and trying to compare them and looking for the baseline, you can look at a couple different scorecards, ATA, CCHP. They don't always agree with each other. They agree on many of the high-level things, but I find myself a little bit surprised sometimes to see how differently some of these organizations rate the same states and the same policies. There's a bunch of fairly technical reasons for that are not terribly interesting. I think, to be honest with you, in some cases, the difference is that some folks just look at the high-level policies and others go all the way through provider manuals and contracts and get a more specific kind of an answer. Probably not worth going blah, blah, blah through every single component of these next couple slides. But I would say, at a high level, the way that these folks score South Carolina is to say that we're one of very few states left that does not have some kind of a private payer law about what services have to be available through telehealth and then what providers should be paid for rendering those that kind of care. The Medicaid score is much more of a mixed bag. I mean, so we get points for certain forms of coverage. We do get points for having payment parity, at least in the Medicaid program, but we are restrictive in some other places. So, as mentioned on this slide, outside of the COVID era, we have a relatively small list of provider types that we allow to bill for telehealth in South Carolina Medicaid. We have a number of originating sites, but not universal. We have, kind of a throwback policy with this patient site presenter rule, where we say that the patient, has to have somebody with them basically, or at the originating site, and then that person has to remain present as clinically appropriate. That's I talked about democratization a few minutes ago. This policy is not really very consistent with that, because it really does make it hard to do sort of direct to consumer style telehealth when you have a rule like this. As I mentioned, these scorecards are, largely in line with each other. You do see a few wrinkles about where they disagree. I think maybe to think ahead to the COVID era, there have been an endless number of Medicaid bulletins issued, not just in South Carolina, but in other states as well, to open up access to telehealth services. This gives a bit of a summary from a report that MACPAC commissioned and had Mathematica put together. We're hardly alone in South Carolina in adding, on a temporary basis, new forms of coverage for telehealth. And it went on and on and on and on and on. And we would have had like 6-point font on this slide if I would have given every Medicaid bulletin separately. But I think the point of this is just to show that, policy making has moved very quickly and very incrementally in the course of the past few months. As things got worse and worse and worse, a few months ago, everybody just kept moving the bar as to what they were suddenly going to be okay with. Things that they had said no to for years, suddenly they were pretty open to. And so in South Carolina, that meant allowing store and forward suddenly, allowing virtual check-in, allowing different provider types, in some cases allowing telephonic contact with members. Eventually a pretty significant opening of behavioral health services. So there's been a lot of movement, but all of it has been on a temporary basis. And where are we going with that? Well, telehealth parity is a phrase that I kind of try not to use, because it's not, telehealth parity is not something that you either have or don't have. It's not a purely dichotomous choice. As I've tried to show in the last couple of slides, it's a much more nuanced kind of question. So yes, it's important to focus on, do providers get paid the same amount of money if they provide care face-to-face versus through telehealth? Yes, it's important to think about, do patients have access to the same, sort of universe of services through telehealth versus face-to-face? But there's a million smaller questions that are all, in many cases, very important to telehealth policymaking, and that also affect patient access to care in many ways that are things that are not necessarily typically thought of as being, a pure part of the telehealth parity question. There are other state policies that are relevant to telehealth. We've seen through some of the federal funds that have been handed off to the state, and then the state makes decisions about how to use it. This summer, the state put a significant amount of that money into improving access to broadband. They also had, in the last draft of the, now current year's budget, language that would try to help Medicaid beneficiaries better understand their eligibility for the Lifeline program. The Lifeline program is a monthly subsidy for broadband service for low-income households. If you are Medicaid enrolled, then you're pretty much by definition eligible. There's some other folks who are as well. Only 20% of the households in South Carolina that are eligible for Lifeline are currently enrolled. And that means that over 500,000 of them are missing out. But there's a lot we don't know about the households that are missing out and why exactly they're missing out. I mean, maybe they have broadband already. They didn't know about the subsidy, so they're missing out on the subsidy and they're paying full freight and they shouldn't be. Maybe they don't have broadband, but they'd get it if they knew about the subsidy. Maybe they knew about the subsidy and said, well, whatever, I can't afford it anyway, so don't worry about it. Maybe they want to have the subsidy and have broadband, but broadband is not available at their home. right? I mean, so we know how many people, give or take, are eligible but unenrolled. We don't know a whole lot about why. And so one of the things that the draft budget we had back in the spring was going to do was put together and commission a study, and then actually Palmetto Care Connections was going to be involved in, to help us understand how many of those 500,000 households fall into which of those little categories at the bottom of that slide. So future of state telehealth policy. One, I mean, there's just an inescapable link to federal action, right? You know, South Carolina is one of the states that kind of explicitly tethered its flexibility to the period in which the federal public health emergency continued. And so if the federal public health emergency goes away, you know, our flexibility here may go away too. They have told us, you know, through more informal mechanisms that they would, you know, they would give us time to react. They would take some time to think about what they would want to make permanent. That's all a little bit up in the air. You know, the purpose of this slide is just to kind of show how scary the federal budget looks like right now. So, you know, that purple line there that goes deep into the abyss shows that, you know, in 2020, the federal government expects to run a deficit that is worth about 16% of the country's gross domestic product. You know, a $3.3 trillion operating deficit is the kind of thing that tends to keep people up at night. And, you know, we've reached the point where, you know, the only real parallel, I guess, is the end of World War II in terms of how much debt is being piled up and what this all represents cumulatively. One of the ways that I think telehealth is going to stay current and present and important in policymaking conversations at the state and federal level is going to be if folks figure out how to present arguments for telehealth in a way that helps to deal with the shape of this curve. There's a lot to learn then on the state level about what exactly happened or is happening during the COVID era. There have been lots of billing errors. I've heard quite a few examples, both from state officials and also from some insurance companies, where, you know, they're trying to tease out, they've seen a ton of billing errors and they're trying to figure out how many of those billing errors on these new telehealth codes are truly mistakes and how much of it is fraud and abuse. And I think that's a little bit up in the air right now. But it's going to be important to the conversation we have after COVID about how much this flexibility should be permanent. You know, when can telehealth displace face-to-face encounters, right? If we have a good argument that telehealth saves money, that really does change the conversation about where we go from here. Plenty of stories out there about, you know, lost revenue for healthcare providers so far in 2020. Big mystery is how much of that utilization is just destroyed, how much of that utilization is never going to be seen again versus how much of it was delayed into 2021. Jury's still out on that as well, but that'll also be in the background as people make these decisions. You know, from a political perspective, there's a pretty broad appreciation among political decision makers that you know, this has been a real kind of coming of age period the last few months for telehealth, that telehealth has shown how it can work in primary, you know, care, and how important it's been to screening and referring people to testing sites during the crisis in a way that reduced risk of infection for both patients and providers. Commercial carriers, I mean, just hate payment parity rules, but do seem to be loosening a little bit on some of the coverage questions. You know, one thing that providers should think about is that we've seen a number of examples, both here and in other states, where when insurance companies realize they have to bend on telehealth policies, the way that they bend is by granting preferred access to telehealth services that either they own or are affiliated with. So something for folks to think about. And then as we sort of drift towards the end here, you know, Medicaid coverage telehealth has many facets. I think we've covered that in the course of the past few minutes. I think, you know, one thing people should think about is really getting a lot more granular and detailed about what exactly would you want to change in South Carolina telehealth policy. Instead of saying, you know, I want parity and we don't have it, I think a way to get something accomplished is probably to start to really take that apart and look at individual policy questions of, hey, could you go into the provider manual and delete this sentence? Could you add this one code? Could you get rid of the rule that says trained staff have to be, you know, present, you know, and immediately available for patients, right? I mean, I think when we start to get at those sort of micro level things, I think it becomes more likely that you're going to get what you're looking for. You know, I think just to sort of close things out, you know, these few bullets here, I think recap much of what I've stepped through over the course of the past few minutes. There is quite a bit that's still up in the air in terms of trying to evaluate the effectiveness and, you know, the value of telehealth over the course of the past few months. but there does seem to be a lot of latent support and appreciation among policymakers for what we've seen during the COVID era. So thanks for listening, and look forward to addressing whatever questions you have.